Thank you. Good morning. I'm Dr. Levitansky, PGY1 EMIM, and here to do a clinical paralysis for neurology. We'll start off with a case, get right into it. Patient comes in, female. I have weakness in my arms and legs. My tongue feels heavy. HPI, 38-year-old female, no significant past medical history, just a thymoma. She comes to the ED with complaints of 1 week of weakness in all the extremities and tongue heaviness, which has worsened for the past 2 days. There hasn't been any pattern to the weakness developing, no fever, chills, chest pain, palpitations, shortness of breath, no dysphagia, no dysarthria, numbness, paresthesias, no abdominal pain, nausea, vomiting, no other symptoms, just that complaint. Just the medical history, the thymoma, and it's not been resected, and she's on no meds. Off the bat, any differentials come to mind?
Well, let's see.
This is a list that I thought of. Again, there's a lot of ones that are not that common, but just things to think about with these vague complaints of weakness. So the ALS, Lambert-Eaton myasthenic syndrome, malignancy, polymyositis, botulism, myasthenia gravis. The most common, you have to really consider electrolyte abnormalities. A lot of electrolyte abnormalities can really present like this with magnesium, hyperkalemia, rhabdo, Guillain-Barré, Miller-Fisher, viral myositis, acute HIV, CVA, tick paralysis, and alcoholic myopathy. I'm sure there's many more that you can add to this list as well. So her review of systems really only significant for fatigue. She's been having this intermittent diplopia for many years with weakness with chewing as well, which is intermittent and worse throughout the day, as well as weakness in all 4 extremities. Physical exam, vitals were all within normal limits, no significant abnormalities in the vitals. The only significant in the exam was that her strength was 4 out of 5 in bilateral upper and lower extremities, 3 out of 5 with neck flexion, 5 out of 5 neck extension, and her reflexes were normal. Significant lab data, really on the CMP, 6.3 on the potassium, but it was hemolyzed. AST, mildly elevated. Her CBC was normal. VBG, really nothing that crazy. PCO2 was 52.7, PO2 was 49.7. Bless you. And TFTs were within normal limits. She is not pregnant. Chest X-ray was normal. But what is significant is her NIF. The NIF is negative 24. So obviously, when we look at the differentials list, what goes really to the top is the myasthenia gravis. We'll discuss NIF very shortly. First, let's do a little bit of a brief overview on myasthenia gravis. As you know, the etiology and pathophysiology, it is an autoimmune disorder. It's actually the most common disorder of neuromuscular transmission. It affects women more than men, like all of the autoimmune disorders. Peak incidence in women is in the 30s, in men it's in the 60s. And we know that it is autoantibodies to the postsynaptic acetylcholine receptors. There's actually other autoantibodies as well, but this is the most common antibody that is found with myasthenia gravis. So, the symptoms of myasthenia gravis, what we see is fluctuating degree and variable combination of weakness in the ocular, bulbar, limb, and respiratory muscles. How do we diagnose it? Is actually serology with clinical symptoms. So you can see the acetylcholine receptor antibodies, as well as the other antibodies that are found significantly less common than the acetylcholine receptor antibodies. We also can do repetitive nerve stimulation and single fiber electromyopathy. The repetitive nerve stimulation has a sensitivity of 75 to 80%, and the single fiber electromyopathy actually has a sensitivity of 95%. And that's the image of what you would see with the repetitive nerve stimulation, that over time with the stimulations, you get less response because the acetylcholine, really, the receptors are bound up. What we're concerned with the emergency medicine aspect of it is really when these patients come in with a myasthenic crisis. Myasthenic crisis was when you have worsening of the myasthenia weakness, which is going to require intubation or non-invasive ventilation. And the situations where you would lead to the non-invasive ventilation or intubation are when you have respiratory muscle weakness, dysphagia with aspiration, weak cough, and inability to clear the respiratory secretions. When talking about the myasthenic crisis, we first have to go into what we need to do with evaluation. We need to do a detailed H&P to rule out any other active diseases or cholinergic crisis. Detailed neuro exam, chest x-ray, EKG, lung ultrasound is beneficial for these patients to see if there's any underlying pneumonia as the pathology. If you suspect a PE, then a CTA PE study would be beneficial because these patients come in short of breath. So it's really hard to determine necessarily, is it a cholinergic crisis? Is it a myasthenic crisis? Is it an underlying pathology such as pneumonia, ACS, CHF, PE? Cholinergic crisis is similar to the depolarizing agents for intubation, so you have to keep that in mind. It can happen from too much of their therapy. So if they accidentally overdose on their pyridostigmine, physostigmine, then it could actually paralyze their diaphragm, and they can come in with a cholinergic crisis. Part of the evaluation is identifying precipitating factors. Many drugs cause this. So fluoroquinolones, things that we very commonly prescribe, aminoglycosides, neuromuscular blockade agents, IV local anesthetics, magnesium, procainamide, beta blockers, antipsychotics. There's a whole slew of lists of medications that can actually throw patients into myasthenic crisis. Infections, mismedication dosages, pregnancy, stress. Part of the evaluation, we want to know certain labs. We would do a CBC to look for any infectious causes or if there's any bleeding. CMP, we want to know all the details of their liver function. We want to know if they have any electrolyte abnormalities. The magnesium, we want to do a VBG, UA, hemoglobin, HCG, we want to know if they're pregnant. That could throw them into crisis. Their TFTs, and if you want to help the medicine folks, you can send an acetylcholine receptor antibody. You're not going to get it in the ER, I imagine. I think this is a send out in both hospitals, if I'm not mistaken. A lot of people talk about the ice pack test with patients with myasthenic crisis. What the ice pack test is, when a patient is coming in, it's really only for patients that have ocular symptoms. If their eyelids are droopy throughout the day, they droop more, you can actually put an ice pack over the eyelids and wait some time, and that actually will increase the amount of acetylcholine and allow more muscular transmission, more acetylcholine transmission through the muscle, and they can have a slight relief of the symptoms. So there's actually, you can add this as part of the evaluation. The edgerphonium test is no longer done in the US, but up until recently, it actually was done. Edgerphonium is an acetylcholinesterase inhibitor. It's very, very short acting. So if it's fast acting and short lasting. So if you administer the edgerphonium, if their issue is that they need a higher dosage of their medication or they're underdosed, then they'll have a resolution of symptoms and it'll only last for a short period of time, and then it'll go away. So that will cue you into knowing that they may need to be on a higher dosage or a higher frequency of their home medication. Or if it does nothing, then potentially there's one of two routes of what that means. Either they significantly need a higher dose, a much higher dose, or they are already dosed well enough and they may be in a cholinergic crisis. Part of the evaluation, we want to know also FVC and NIF, negative inspiratory flow. So there's a lot of different theories which say that FVC evaluation is actually much better than a NIF. FVC is a forced vital capacity. It evaluates the largest breath that a patient is able to take. It's a much more holistic evaluation because it takes into account multiple parameters of the breathing cycle, which is the inspiratory strength, expiratory strength, lung compliance. Whereas the NIF, the negative inspiratory force, really only measures the strength of the diaphragm. And per a lot of studies that I was looking at, it's much less reproducible than FVC. So when you are continuously monitoring these patients with either a NIF or an FVC, every 8 to 12 hours, you want to have something that's really reliable to know where the trend is going, if they're getting worse, if they're getting better, or they're staying the same. Just a little bit about the NIF. So I didn't know what this was actually until I had the first myasthenic patient that came into CCT, and the senior resident was talking about NIF and I had no idea what it was. So it's actually very, very simple and basic. There's different kits out there. The respiratory therapists over here in Kings County can do it. There's just a little meter that attaches with a hose to a mouthpiece. Patient's nose is blocked off, and it's important to instruct the patient to do this to get a good number with this, because The NIF, you're really trying to measure the strength of their diaphragm and their respiratory muscles, not their cheeks. So when you have them inhale, you want to instruct them not to breathe in with their cheeks, just breathe with their diaphragm, inhale with the diaphragm. And you're actually measuring negative numbers. So a NIF negative 60 is associated with only a weak cough, which is actually pretty good. But a NIF less than 30 is really indicative of severe muscle weakness, where you have to really consider, do they need any alternative to, like, do they need non-invasive ventilation, or do they need intubation for their weakness? Management of patients with myasthenic crisis. First thing, obviously, ABCs. Decide whether the patient will need any respiratory support, and if they need respiratory support, what mode of respiratory support you're going to use, whether it's high flow nasal cannula or BiPAP. These methods of non-invasive and BiPAP are really only for patients that are early in crisis, that only have mild distress, and the goal is really to reduce their overall work of breathing and prevent respiratory exhaustion. Once they already are in that period of respiratory exhaustion, then you have to really consider endotracheal intubation. What's important with endotracheal intubation, if you choose to intubate, this is a clinical decision. If you choose to intubate, there's a lot of conflicting information with which agents of induction you should be using. There's a lot of people that say that you should not be using any of the depolarizing or non-depolarizing drugs, because essentially those work on the acetylcholine receptors and the neuromuscular transmission, which the disease is affecting right now. So some say that if you use a half dose of a depolarizing agent, that would be okay. Some say stay away completely from the non-depolarizing agents, because there's really no way of knowing how they're going to work with these patients, if they will work, and how long the effect will last for. So if you're choosing intubation, there are many places that say that you should really just stick to awake intubations and maybe using etomidate and fentanyl or propofol as opposed to neuromuscular blockade. And of course, when talking about the ultimate disposition, these patients are going to need close airway monitoring. So they should be in CCT or in the resus room and downstate, and the dispo should be in an ICU setting. So management for a patient that comes in with a myasthenic crisis. First thing we have over here, the ability
Please speak up with drinking light.
for a neuroconsult. That's number one. Next, we can talk about the management with a patient that has myasthenia gravis in general. They're on prostaglandin, physostigmine, any of the acetylcholinesterase inhibitors. And what they do is they keep the acetylcholine in the neuromuscular junction for a longer period of time, and it will competitively inhibit the receptor antibodies to allow remission. Dose for crisis would be 60 to 90 milligrams PO every 4 to 6 hours. Onset is about 15 to 30 minutes. The peak action is approximately 2 hours, but be aware that due to actually cause a cholinergic crisis by increasing precardia, that the patient is already intubated, if they that bad that they have to be intubated, maybe consider withholding physostigmine until the patient is already being weaned from the vent. Plasma exchange is another treatment. What we do is it directly removes the acetylcholine receptor antibodies. It's the first line for a severe exacerbation. Its onset is within a few days. It actually doesn't take time. It takes a very long time to work, and its effect lasts 3 to 4 weeks. The way plasma exchange is done, it's actually done in 5 different sessions of exchanges. Each exchange is 3 to 5 liters of plasma, and it's done over 7 to 14 days. IVIG, the proposed mechanism is that if you give an antibody to the antibody receptor, then it will pull them off. But the exact mechanism is truly unknown. Its onset also, it takes quite a bit of time to work. It starts in 2 to 3 weeks, and its effect lasts longer than the plasma exchange. The advantage of IVIG is that it's much more readily available in many centers, whereas plasma exchange may not be readily available in many of the centers. And the dose for IVIG is actually 2 grams per kilo, and it's divided into 2 to 5 days. There's also the immune modulating therapy. High dose prednisone is one of the immune modulating therapies. So you have glucocorticoids, azathioprine, mycophenolate, cyclosporin. The high dose prednisone is 1 milligram per kilogram daily. Its onset is 2 to 3 weeks. Its peak effect is 5.5 months. So actually, its peak effect is way later in the game. If you are going with glucocorticoids, one thing to keep in mind is that in 50% of patients in myasthenic crisis that are treated with glucocorticoids, they actually have a transient worsening of their symptoms. 10% of those patients end up having to require intubation with mechanical ventilation. So it's something to really consider before you just blast these patients with high dose steroids, that they could potentially get worse. It will not likely happen in the ER. The worsening occurs generally 5 to 10 days after you administer the steroids. But it's something to really think about when deciding what you're going to choose to treat, or along with neuro, what you guys choose to treat. The risk is ameliorated a little bit when you start plasma exchange or IVIG, because those start taking effect by the time you have that transient worsening of symptoms. And then, of course, thymectomy is a treatment down the line for these patients. It used to be thought that thymectomy was pretty much curable for the myasthenic patients. However, really only 10% of myasthenic gravis patients have a thymus tumor. And what they saw is that majority of them that even have a thymectomy, they actually have recurrence of symptoms later on in life. So it's not actually curative. Takeaway points: when you have a patient that's presenting with you suspect a myasthenic crisis, the first thing you should do is actually rule out the other etiologies of dyspnea in patients. Don't just jump to say, oh, it's a myasthenic crisis. Really consider whether it's pneumonia, CHF, PE, or a cholinergic crisis. What you really should do is try to evaluate the FVC when possible, and you should trend every 8 to 12 hours for patients that are stable. I only had 2 myasthenic gravis patients over here so far, and we did NIFs. A lot of the data is actually supporting the FVC as a much better measurement to follow than the NIFs, because it's much more holistic. And the NIFs really are all over the place with their numbers. And I actually saw that with one of the patients that I had that we did the NIFs. One NIF was like 45, and then an hour later, when neuro came to evaluate the patient, they didn't trust it. They did it again, and it was 26. And then the respiratory therapist did it again. So the numbers were all over the place, all within a very short time frame. And the patients actually clinically did look the same. So maybe we should be doing FVCs more than NIFs when we evaluate these patients. If we're intubating a patient with myasthenia gravis, we should really avoid the depolarizing agents for intubation. We should consider the awake intubations with etomidate and propofol. And when managing patients with myasthenia gravis, consider that many of the medications that we commonly prescribe can put them into crisis. So even if they're just coming in for a UTI, consider which antibiotics you're going to give them. Really counsel them on being aware of this could potentially put you into crisis, know the early signs, and contact your doctor and come to the ER as needed for it. And here are my references. Are there any questions?
Boy, that was very thorough. You really put a lot of work into that. I'm impressed. I had a couple comments. One is something that you emphasized. Almost every time I've seen this, they usually have a pneumonia. And you emphasize that as well. And you want to be aggressive always in treating the underlying cause, and particularly pneumonia, and picking the right antibiotics for it. And the other question is, could you go over again very briefly how to distinguish between an overdose of the medicines like pyridostigmine versus not having enough? You mentioned it. Just could you do it again real quick?
It's actually pretty challenging in many cases to determine whether it's too much medication or not enough therapy. But generally, if it's too much therapy, you have a lot of the cholinergic effects. So they may be bradycardic, all the cholinergic toxidrome symptoms. Whereas if there's not enough therapy, they have just the muscle weakness in most cases. You could do an edgerphonium test. I don't know if we have it available here, but technically you could do an edgerphonium test to really see whether they are just not enough therapy. If you give the edrophonium and their symptoms resolve, that means that they don't have enough therapy.
But if they had too much and you give it, then you're kind of going to have to intubate them due to liquid secretions. I don't know if I'd recommend that.
Yeah.
You want to be a little bit more sure when you do it.
That's when the ice pack test can be really useful.
Yeah, you want to do something that's non-invasive and not dangerous. The ice pack test is probably a good idea to start with, and then get neuro on board and get their opinion.
The ice pack test will only be valuable if the patient also has the ocular symptoms. If they don't have the ocular symptoms, then we really can't do the ice pack test.
That's
That is
true.
definitely
Sometimes
true.
if they don't have the ocular symptoms, you can induce them if you have them repetitively blink, and it'll induce some ptosis.
The other thing is, don't forget that downstate the neurology department is really probably has all the myasthenia known myasthenia patients in Brooklyn. You know, it's really a center of like a big field. They know that. Remember.
So they were sick because they were saying no to the sucks because even though it will work with a higher dose, it's unpredictable how long it'll last. And then it'd be more challenging once you have therapy to wean them from the vent because you don't know how long it'll be in their system for.